Program PSL memberikan kesadaran melalui pemberian sekali sehari, mengurangi intrapasien variability untuk memberikan kadar tacrolimus yang konsisten dan dapat memperbaiki tingkat kepatuhan pasien, di mana keduanya dapat meningkatkan outcome jangka panjang. Program XL.
Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen, all esteemed professors, urologists, residents, general practitioners, and all medical students who are joining us right now. Allow me to introduce myself. My name is Utari, and I will be your host for tonight's event. Welcome back to Jakarta Urology Medical Update 2020. This is a series of events organized by Yayasan Pengembangan Urologi Jakarta that discuss various topics in urology with both international and national speakers. This session is sponsored by PT Astellas Pharma Indonesia, and we are glad to say that this event will also support the COVID-19 relief effort in Indonesia by donating some of the registration fee. Today, we are having the final session of our 6-day webinar, where we will discuss all about transplantation and its update from our esteemed panelists. Without any further ado, we will start the main session of the night. I would like to kindly invite our moderator, Gerhard Renaldi Situmorang, MD, PhD, to lead and moderate the main session and discussion. Gerhard Renaldi Situmorang, MD, PhD, was born in June 13, 1983, graduated as medical doctor from Faculty of Medicine, Universitas Indonesia in 2007, as a urologist also from Universitas Indonesia in 2013, and obtained his PhD at Newcastle University Institute of Transplantation, Urology and Renal Services, Freeman Hospital, United Kingdom in 2018. Dr. Aldi is currently active as staff of Urology Division in Cipto Mangunkusumo Hospital. Please give a warm welcome to Dr. Aldi. Dr. Aldi, the time is yours.
Thank you very much, Dr. Utari, for the nice introduction. I welcome you all, ladies and gentlemen, to our last jam session this evening. And I'm happy to tell you that we have an esteemed panelist today with us. tonight's sessions, we will hear and discuss about 3 topics in kidney transplantation. But the main topic will be recent advances in kidney transplant recipient surgery. And later on, we're going to discuss about how we perform our living kidney donation program in Jakarta. Tonight, we have 3 experts. I should say they're not only experts, but also pioneers in their respective field. We have Professor Franzel Modi from India, and then Dr. Angelo Territo, PhD from Italy, but currently work in Barcelona closely with Professor Alberto Breda, and of course, Dr. Nur Rashid from Jakarta, Indonesia. We want to remind you again that during this session, we will give the opportunity to all participants to ask and discuss about these topics to our speakers by directly writing your questions in the Q&A column. The committee and I will sort these questions and ask them to our panelists in our discussion session later on. Without further ado, I would like to start our first session. Professor Franzel Modi. I'm sure we all here know Professor Franzel Modi. He is a professor and head of the Department of Urology and Transplantation Surgery in Institute of Kidney Disease and Research Center in Ahmedabad, India. His medical education, following his medical education and specialty study in MP Shah Medical College, he moved to the IKDRC to study about urology and kidney transplantation. He pioneered retroperitoneoscopic living donor nephrectomy and helped establish programs globally, I should say, including in India, UK, Germany, and Australia. He has done the largest series of laparoscopic kidney transplant and liver transplantation in public sector in India, and he's been instrumental in the robotic kidney transplant with regional hypothermia technique, and is one of the most experienced surgeons in the world with this technique. So without further ado, I will invite Professor Franzel Modi to give his talk. Please, Professor, the time is yours.
Yeah. Thank you very much for the kind introduction. Am I audible? And shall...
Yes, Prof, clearly.
And I'll just share the screen. Yeah. Is my screen visible?
Yes, clearly, Prof.
Yes. So we'll talk about the robotic assisted kidney transplantation. The first question is, why do we need minimally invasive kidney transplant surgery? The answer is clearly various incisions for kidney transplant are described, and they are often very large incision. Incision could be like a hockey stick or a paramedian or sometimes midline incision. Various incisions are described. The pain and requirement of analgesics has never been the issue in the past till the development of the minimal invasive transplantation surgery has emerged. The immunosuppressions and the side effects on the wound are very well known, especially when you give the pulse steroids or maybe the mTOR inhibitors we need to give. The wound weakness is known and the risk of infection and seroma formations are higher with the higher immunosuppressions. And hence there is a need to minimize the wound length also. And the risk factor for impaired wound healing are very well known in general surgery. These are the obesity, diabetes, malnutrition, etc. We first described the laparoscopic kidney transplant with a very initial experience of 4 cases when the kidney was obtained from a deceased donor and often the terminal creatinine was raised. The ethics committee gave us the permission to go with the kidney transplantation done laparoscopically. What is most important in this particular slide is that the laparoscopic kidney transplant anastomotic time was almost an hour or more than that. However, there was a good function of the graft, and there was no dialysis required post-operatively in any of these 4 patients. The graft survival was fantastic at the end of 4 years. Subsequently, we carried out the retroperitoneoscopic living donor nephrectomy and laparoscopic kidney transplant in 72 cases. We found that with the experience, though the anastomotic time reduces, but still it was always about 45 minutes. And that clearly indicates there is a need to improve for reduction in the anastomotic time because few delayed graft function can occur. Though the graft survival and patient survival did not differ in the open and laparoscopic kidney transplantation, There is a need because the long-term outcome of transplant we were not knowing at that point of time. This cartoon suggests that there is a jug half full of water and crow wants to drink the water. To bring the water up, he has to do a lot of hard work, and that is laparoscopic surgery. While today's smart crow can just put a straw inside and drink the water, and that is a smart surgery. What we need to understand that smart surgery is a robotic surgery. The initial experience of robotic kidney transplantation is shown by the various authors. Way back in 2002, Hosnek in France has done first robotic kidney transplant, put an incision, 7 centimeter incision in iliac fossa, and the transplantation was carried out by means of robot. Gironati subsequently did the first robotic kidney transplant in 2010 in an obese recipient. So between 2002 and 2010, there was a huge gap for development of this particular procedure. The Hugo Bogie has carried out successfully first robotic kidney transplant in 2011. We started our experience and getting learning of the robotic kidney transplant by training at Roswell Park Cancer Hospital, and subsequently in collaboration with Dr. Mani Menon and the team from the Medanta Medicity at India, Delhi, we started doing the robotic kidney transplant. Clearly, the advantages of robotic surgery are trimmer filtration, 3D vision of the surgeon, better visualization of the planes, better ergonomics, and 7 degrees of wristed movements of the instruments. This is the position of the patient. This 30-degree Trendelenburg position. Head is on this side. Both the legs are separated out, and robot is docked. We are SI robot. Robot is docked between the 2 legs of the patient, and the robotic ports are used, forearm are used to put the instruments in. Initially, we used to put the 2 assistant port. Now we reduce it to the 112 millimeter assistant port. You can see the posterior peritoneum is incised. This is the peritoneum covering the external iliac artery. And you can see the large lymphatics are often seen, which we can displace. There is no need to cut. So vision is so good that even the lymphatics can be seen clearly and you can displace, which is very difficult sometimes to see even with magnification by the loop in open operation. The medial dissection should reveal the vein, external iliac vein, which we can dissect out, and the lateral dissection of the flap of the peritoneum is made. And this is very important because the kidney will be flipped into the retroperitoneum, and this flap of the peritoneum will be covering over it. We put several clips at the edge here, and you can see here the peritoneal edge close to the cecum. So this will be approximated, and the kidney will be retroperitonealized. At the same time, we put a 7 centimeter incision, which is a phalangeal incision. Both the recti are to be separated in the midline. So there is no muscle cut except the aponeurosis. Nothing is being cut. So the incision is almost painless. On bench, we prepared the kidney. This kidney had 2 vessels. Both are anastomos on the bench, side-to-side anastomosis. The marking stitch is placed at the upper pole of the kidney so that the upside-down transplant can be avoided. Also, the marking stitch is placed on the artery upper edge, the venous upper edge, and also at the tip of the ureter. The kidney is wrapped around with the gauze piece in such a way so that the handling of the kidney is done only by handling the gauze piece rather than the parenchyma itself when we put the kidney in the abdomen. This is how just we drop the kidney in, and immediately with the suture on, this wound is closed. There is no need to put expensive devices like a hand pot or a gel point, and this can cause sometimes it's a lot of expenses associated. Already the robotic surgeries are expensive, and we should avoid the further expense. Now, with the robotic pot scissors, we do the venotomy. You can see the external iliac vein has been opened up, and then this left-hand surgeon is doing the suturing of the back wall and followed by the front wall. And then we apply the 3rd bulldog clamp on the renal vein, and the 1st and 2nd bulldog clamps which had been applied on the renal vein are removed and placed directly on the external iliac artery. So these are the bulldogs placed on the external iliac artery, and with the robotic pot scissors, we put another small arteriotomy which can be extended by means of a black diamond forceps and the robotic pot scissors. So you can create a circumferential arteriotomy. The blood and the clots are washed out by using the ureteric catheter through the assistant port, and you can see then after the arterial anastomosis can be carried out very easily by means of robot. And then this is the perfusion of the graft. You can appreciate the graft. The turgidity of the graft can be appreciated by using the robotic instrument. There is a lot of debate about the haptic mechanism, but I think with the experience we learn how to what is the turgidity. The color also is very important. Once the graft is pink and perfused and urine starts coming, we can flip the graft onto the psoas muscle and cover it by means of peritoneum. Then the bladder is usually dropped down, and most of the urologists know that the procedure is done frequently in robotic radical prostatectomy. The submucosa and mucosa are dissected out, and the detrusor muscle is separated out here, and you can put a small rent on the mucosa, and then after full thickness of ureter with the mucosa is anastomosis. We do the interrupted anastomosis with the 5K40. You can see the loop of the Prolene stitch here. That is to use the manipulate the ureter. We do, because the robotic instruments are too robust instrument, and the injury might occur on the wall of the ureter is could be robust also. So to avoid that, we use the stay sutures. This is the detrusorography which we can carry out. Now the kidney is split and this peritoneal flap is covered, and that's how we do the partial retroperitoneization of the kidney. We see the result. I could collect the data up to April 2018. I think that till that time we have done a 400 robotic kidney transplant. By this time we have done over 535 robotic kidney transplant. So out of that, 356 were adult patient and 303 cases were from living donor. We are going to discuss this 303 cases data with the 428 cases who had undergone the open kidney transplant. There was no demographic difference in the age, sex, or the BMI. What is important, however, as the experience increases, there is significant difference in a blood loss. That is much lesser blood loss in robotic kidney transplant compared to the open kidney transplant. OT time has started reducing, so robotic kidney is getting faster now than compared to the open kidney transplant, and reimplantation time is also a much lesser compared to the open transplant. The drop in serum creatine value compared to the open kidney transplant is faster or almost equal. There is no statistical difference, but and it remains same for more than 4.5 to 5 years now. So this is very important that the outcome of transplant is comparable. There is no difference in a graft survival or a patient survival in open and robotic kidney transplantation. Coming to the immediate post-operative data, the mean length is around 6.9 to 7 centimeter, and open kidney transplant is around 18.8 centimeter. Analgesic requirement is less as expected. The time to resume orally is also equal. There is no difference, and the time for ambulation is also much faster in robotic kidney transplant. The time of catheter removal there is no difference, as well as there is no difference in post-op hospitalization. At my institution, we have started now reducing the hospitalization of both the patients, especially in a COVID time, and we encourage them to go home on a third or fourth post-operative with the catheter on. The complications, conversion to the open operation required in 5 cases. Out of that, 3 cases had arterial thrombus. Intraoperatively, there was no flow detected, and 2 had a bleeding. All the 5 cases were very early cases. Urinary leak was observed in 3 cases of robotic kidney transplant, and 1 had a renal vein thrombosis. The patient, that patient also had a bleeding. It was a right kidney, and there was a tear in the right renal vein, and subsequently graft loss occurred because of the renal vein thrombosis. The post-transplant biopsy was required. Since we flip all the kidneys and put in extraperitoneal space, there is no problem. But in one case, the transperitoneal laparoscopic biopsy was required because there was no window available due to the bowel adhesions. The no lymphocyte is a very important finding. Probably the minimum dissection of the vessels, all the lymphatics of the graft side are ligated very well, good bench preparation, and transperitoneal approach might be contributing to the no lymphocyte. And because of that, there was no de-lymphing is required, which is there in 6 cases of a open kidney transplantation group. There was no the hypothermia occurred in 3 patients. Initially, we used to put a lot of ice around the kidney, but after first 50 cases, since 3 patients had developed hypothermia, temperature went down to 94 Fahrenheit. We need to stop doing that procedure, and now we do it without any hypothermia, without any difference in outcome. And all these 3 patients plus 5 another patient develop mild lactic acidosis and require a late extubation of the recipient. So the hypothermia is completely removed. Since then, we didn't find this type of problem. The robotic assisted dual kidney transplant is the next step forward. Like we got the several marginal kidneys, so in that case, can we go proximally and do the anastomosis with the common iliac vessels, right? This is the dissection done. Common iliac artery is looped here. You can see the uterus and ovarian vein. It's a female recipient, and these are the external iliac artery and external iliac vein dissected out. The first allograft is placed inside. You can see the Carrel's patch, and then here is the common iliac vein, which was isolated. In this case, instead of laterally, it was located a little more medially, and hence we pull it out from here rather than from the lateral aspect. So here, this is the bulldog clamp applied, and then first venous anastomosis is carried out with the common iliac vein. Again, same principle is same, but the third bulldog is applied on the renal vein, and then both these bulldogs are removed. So that will restore the lower limb circulation, especially venous drainage. And then with using the Carrel's patch, putting a large arteriotomy in the common iliac artery, the anastomosis, the common iliac artery, the graft is perfused and then flipped on the psoas major muscle. And now the second graft, which has been placed inside, and then distal anastomosis, the anastomosis with the external iliac vein. You can see this is the extension of the vena cava, right renal vein from the vena cava is done from the deceased donor graft, and we can do the anastomosis of the artery here. And then that kidney also is flipped on the first kidney. This is the first kidney. This is the second kidney, and the peritoneal flap, which is covering both the graft. And this is the cecum, and this is the curettage of the peritoneum, which is brought close to the curettage of the flap of the peritoneum, and then several clips are applied. So that's how we retroperitonealize both the grafts, and that is a fantastic outcome with that. With the implantation of the ureter done separately, because this is our practice. One can do the joining of both the ureter on the bench also, but we prefer to do it separately because there is a chance if one ureter is necrosed or leaked, then the other ureter should not be affected. And this is the post-operative outcome. It was a obese recipient, and you can see just through the 7 centimeter incision, one by one, we can place both the kidney and do the transplant. One is in common with the common iliac vessel, another with the external iliac vessel. And the outcome. This is recently which we have published also. The offlet, we have done the transplantation by putting the kidney through the vagina also. I'm not going to discuss that part, as well as the pediatric kidney transplant. In summary, laparoscopic kidney transplant and robotic kidney transplant are technically feasible, and compared to the open kidney transplant, requirement of the analgesic is much less, and the blood loss is also less. Cosmetically, it appears much better. Robotic kidney transplant is associated with the less blood loss and quicker than the open kidney transplant in our experience. And we have used the vagina. I should delete this as a conduit to transfer the kidney into the abdomen. However, I have not shown it here. Robotic kidney transplant is associated with reduced warm ischemia time compared to the laparoscopic kidney transplantation. So the initial anastomotic time, which was initially 60 minutes, which is brought down now to 30 minutes or lesser than that. And it is feasible in children also. And the robotic assisted dual kidney transplant into monolateral iliac fossa is feasible and safe. What is important is large randomized multi-institutional trials are required to evaluate the benefit of the robotic kidney transplant over the open kidney transplant. Thank you very much, and I am open for the questions.
Thank you, Professor Modi, for the insightful presentation. If you don't mind, we would like to move on to the second speaker first, and then we will going to discuss later on after all speakers have presented their presentations. The second presenter tonight is Dr. Angelo Territo. Now, Dr. Angelo Territo has. Yep. Can you hear me clearly, Angelo?
Yes, I can hear you.
Okay. Right.
I'm going to share my presentation if I can.
Yes. And while you do that, I'm just going to introduce you to our audience, Dr. Angelo.
Yeah.
So Angelo Territo graduated from University of Palermo in Italy in 2010. He's a graduated as urologist also from University of Modena and Reggio Emilia in Modena, Italy. Got his PhD from the same university. He obtained European Association of Urology Award, Renecus Prize in 2018. He won EAU-based Best Paper on Clinical Research Award in 2019 and Columbus Award for the third best video from the Italian Urological Association. He does not only work with kidney transplantation, he also do a lot of endourology procedures, including uro-oncology, especially, I think, your latest research in upper urothelial tract carcinoma. Again, currently, Dr. Territo works in Barcelona, closely with Professor Alberto Breda, also one of the pioneers in robotic kidney transplantation. Without further ado, I would like to give you an opportunity to share your experience, Dr. Territo. Time is yours.
Good afternoon. Thank you very much for the invitation. It's a really pleasure for me to be here, to be invited in this meeting of Jakarta on the section of kidney transplant, talking among experts in urology and particularly in kidney transplant. A talk on introduction of immunosuppressive regimen and the evidence of robotic kidney transplant. As we know, there was a rapid increase of the availability of the drugs in the immunosuppressive treatment in the last 50 years. And thanks to my colleague from nephrology unit, it is the mechanism of action complex, probably to understand for the for surgeon, at least for me, the mechanism of action of this drug when we treat the patients underwent the kidney transplant. Anyhow, what we need to know as a surgeon, I think, is that the kidney transplantation, when we do a kidney transplantation, an induction therapy is required to prevent acute rejection, and a maintenance therapy is needed in order to avoid any rejection on the long term. Yes, there are main limits, several limits related to this kind of therapy, including nephrotoxicity, including cancer, de novo cancer, including cardiovascular events, and so far the combination of calcium urine inhibitor and purine basis inhibitor and steroids are commonly used. The current trend is try to use tacrolimus instead of cyclosporine, and the mycophenolic acid instead of tiroglobulin in case of kidney transplant, in order to avoid any nephropathy. So by doing that, in our institution, where more than 120 kidney transplants per year, including deceased donor and living donor, are performed. The regimen includes thymoglobulin during the first week and basiliximab for kidney transplant from living donation, tacrolimus, mycophenolic acid, and steroids. By doing that, the incidence of acute rejection is within less than 7% within the first year. So, despite the limits and the problems related to the kidney transplant and the problem related to the immunosuppressive therapy, we know that a kidney transplant is the preferred treatment for patients affected by end-stage renal disease. However, we know that I cannot go on. I don't know what. Okay. We know that patients undergoing kidney transplantation are often fragile, immunocompromised, with an increased risk of peri and post-operative complication. For this reason, as we already discussed by and illustrated by Professor Modi, there was in the last 10 years there was a need for reducing the invasivity, reduce of the morbidity related to the conventional open surgery in kidney transplant, because the idea was that the transplant recipient may gain from a minimal invasive approach. This is the reason why in 2010 the first procedure was performed in kidney transplant by doing laparoscopic, but laparoscopy, at least in my opinion, is too demanding when we want to do a kidney transplant. Doing vascular anastomosis laparoscopically is too difficult, at least for the majority of surgeon community involved in kidney transplant. That is the reason why I think just few surgeons, including Professor Moody, are really able to perform successful kidney transplant laparoscopically. United States, almost 10 years ago, so the experience in robotic kidney transplant has been started with the experience of Professor Giulianotti working in Chicago, when in 2010 he described the first cases of robotic kidney transplant in obese population. But the standardization of the procedure has been carried out by Professor Menon collaborating with Professor Alawat and publishing the result in European Urology in 2014.
Angelo, I think we lost you there. Yes, so sorry about that technical glitch. While we sort Angelo out, Prof. Modi, I hope you don't mind to answer some of our audience questions.
Certainly.
So there are two questions related to retroperitoneal sort of placement of the allograft. First is, why do you prefer to use clips? Is it because it's just simpler? That's the first question. And the second, have you encountered any cases where there's not enough peritoneum to cover the kidney? What do you do then? I think those are the two main questions. Please,
Yes.
Prof. Modi.
I think both questions are very good. We found the clip is easy to deploy because clips are to be applied by the assistant surgeon, and you don't have to put more than three or four clips at the most. And that's why very quickly you finish the job. And there are continuous running sutures can also be used, but then it takes a little more time. Just it's a matter of time, and that's how we have ended up with applying the Hemolog clips. That's one. You can use the suture. That is not a question. It's a very versatile thing. The second question is about. Can you repeat the question?
If you don't have enough peritoneum to cover, what do you do?
Then it is we mobilize the cecum and we try to put the kidney behind the cecum, so it sticks there rather than we try to keep it in the pelvic cavity. So, however, in some occasion, like 2 or 3 occasions, we have kept the kidney in the pelvic cavity itself, especially when there is a right kidney and very short renal vein. Trying to flip it can cause the traction on the vein, and then it may have a potential chance of bleeding. So in a very early part of our understanding about robotic kidney transplant, we place the kidney there in a pelvic cavity only. The caveat is if you require later on biopsy, you have to go for the laparoscopic biopsy. So that is the reason why there is a need to transfer the kidney in a retroperitoneum. But these are the two things. One is keeping the kidney behind the cecum, or other thing is kidney putting into the pelvic cavity. These are the two options you have.
So, do you think the same apply in open surgery, Prof? Can you just place the kidney behind the cecum if you don't have enough peritoneum to cover it?
Yes, certainly. It can be applied even for the open operation. Open, usually we do extraperitoneally as such also. So there is no problem in putting it up. And in fact, there is a paper from Norway where they put the several fenestra into the peritoneal cavity to avoid the lymphocyte formation. And they found that is effective in a few of the cases. In their series, there was a much reduction in the lymphocyte. So the peritoneum absorbs, and what we do when the lymphocyte forms, what we do is that we put the transperitoneal deroofing of the lymphocyte, and drain the lymph into the peritoneal cavity, where the fluid gets absorbed, and you can get cure of subsequently. So I think these are the various techniques used. Complete coverage by the peritoneum is not desirable. Just we cover it with the uppermost part and the medial part only. So lower part of the kidney is open, and the fluid can drain down into the abdomen, into the peritoneal cavity.
Okay, thank you, Prof. Another technical question: have you ever had to do anastomosis with to the native ureter instead of the ureteroneocystostomy? And in what cases did you do that? What are the results?
Yeah, only one case I had to do it, where during donor nephrectomy there was a cautery injury to the ureter, upper ureter. So when we took out that kidney, we found that there is a significant injury, and we divided the entire ureter and dissected out the upper ureter with the pelvis. And that was spatulated, and then we carried out end-to-side anastomosis with the native ureter, and it worked very well. There was no problem. In that case, however, we use the stent. Routinely, we don't put a stent, but when you do the ureteric anastomosis, we use the stent.
So in all your ureteroneocystostomy cases, you never use any double J stent, yeah?
I never use the double J stent.
Right. Okay, that's interesting. And I saw that your complication rate was pretty low as well.
Yeah, true.
Okay. Great. Now we have one question from Malaysia, Prof. This is Dr. Vijayan from Hospital Kuala Lumpur. How many cases did it actually take you to bring down your cold ischemia time to under 30 minutes, Prof. Modi?
Yeah, it's very good question. It took around 35 cases to bring the cold ischemia time less than 30 minutes. So, and this is recently, I think Dr. Breda's publication is also there in European Urology 2018, where the learning curve is around 30 to 35 cases. And once you do about that much cases, probably, in my time, there was no mentor. If you have a mentor, probably that time could be reduced further. That is also the reality.
Great, thank you, Prof. Can I just confirm with the committee whether we have Dr. Territo back in our platform?
Sorry.
Yes, you're back, Angelo. Glad to see you back.
Sorry, but I don't know why. I have a problem with my connection. I don't know why.
Glitch is a glitch, Angelo. I'll give the time back to you to finish your presentation. Time is yours.
So maybe I start from here, no?
Yes. I think the last slide you presented was about the United States experience, so the historical aspect of robotic kidney transplant.
So, starting from the experience of United States in 2015.
Sorry, Angelo. Before we start, can we have your slideshow? Is your slide?
It's good. Can you see my presentation?
Not yet, I believe. Can you?
Okay. I have to share my presentation.
Yeah, just share screen and put it up.
Problem of the direct.
That's no problem. So while you sort that out,
now you can see it.
Yes, absolutely.
Okay. So I restart from this. So I was talking about our experience starting in 2015. In July 2015, when the European experience of robotic and transplant started, thanks to the idea of Dr. Breda in Barcelona and Dr. Dumerque in France. As previously said, Professor Moody, a first attempt of robotic and transplant was carried out by Professor Boggi, an Italian surgeon at University of Pisa. But the procedure performed by Professor Boggi was an hybrid procedure. In other words, he performed the vascular anastomosis robotically and ureter implantation open fashion. So the really pure robotic and transplant were carried out in July 2015, same day, without any previous agreement by Professor Dumerque and Dr. Breda in Toulouse and in Barcelona, respectively. So, starting from this, in 2016 was created a EUROS working group with the aim to collaborate and to collect data using a common online registry, and where we collect the data from the donor and from the recipient. The recipient underwent a robotic kidney transplant. Thanks to this collaboration, to hide our data and to publish our first article in 2017 on European urology. It was a series on 120 cases where operative surgical outcomes were analyzed in terms of operative time, vascular time, intraoperative complication, post-operative pain, time for double J removal and hospital stay. And also functional results were analyzed, figure out how that the creatinine and the GFR, creatinine progressing down during the first post-operative month, and the GFR progressively increased during the first 30 days. I think that we should pay attention on rewarming time when we do kidney transplant robotically. Rewarming time is an issue related to the procedure, related to the technique. Is the time between the graft is introduced in the abdominal cavity until the declamping, when once the anastomosis is performed, the vascular anastomosis is performed, and the artery and vein are declamped. This time potentially could be dangerous for the graft because of the exposure of the gas of pneumoperitoneum, because of the high temperature inside the abdominal cavity, despite the continuous ice slash added around the graft. In our series, we demonstrate scientifically, that rewarming time does not affect the functional result of the graft. Complication rate are important to discuss. We know in the literature, in the open approach, there are several complications. The morbidity of the open transplant is high because there's several complications related to the technique in terms of wall infection, lymphocyte, and arterial thrombosis. In our series, we recorded one case of wall infection, one case of lymphocyte, and the lymphocyte is the rate of lymphocyte is low because of the transperitoneal approach. Once the anastomosis is completed, we flip over the kidney on the top of the muscle, of the muscle, and then we cover the graft with a flap of peritoneum, leaving some windows through the lymph can reabsorb, can drainage by the peritoneum cavity, so that this is the reason that can justify why the lymphocyte is almost a rare complication, or let me say it's a rare complication in a robotic transplant. We recorded a serious complication as arterial thrombosis, 3 cases of arterial thrombosis, but we should say that I would like to emphasize that this complication happens during the learning curve in the first post-operative week of the transplant, and during the first case is performed in 3 different centers. So that we should underline also that these complications are also absolutely in line with the complication rate in the thrombosis in the literature. Aesthetic results, I think, are important to consider because more and more we are transplanting young ladies, we are transplanting young people where the aesthetic result should be allowed, should be considered. As you can see here in this picture, at 3 months, on the right side of the picture, at 3 months or after surgery, the scare is minimal around the umbilicus in the midline. 1 year later, we published our result in a series of 83 patients with a minimum 1 year follow-up, and we demonstrated that there were no statistical differences between the function result at the first month and first 1 year follow-up in terms of creatinine and GFR. In terms of complication, we already discussed about graft survival and the 3 cases of graft loss that we recorded. In terms of late complication, we recorded 1 case of ureterial stenosis and 1 case of graft pyelonephritis. So low complication, again, low complication in comparison to the literature from the open experience. We demonstrate again that we can do the kidney transplant, robotic kidney transplant, using multiple vessels. Many times we know that we have multiple vessels. We prefer, at least in the majority of the centers, to perform the procedure by open surgery with the conventional approach. In this article, we demonstrate the possibility to do the same procedure in case of muscle. There are no differences in terms of vascular anastomosis rewarming time. There are differences in terms of cold ischemia time, yes, because we need time on bench stable to reconstruct the artery, for example, to do a situs of the artery. Obese recipient majority. Can you hear me? Can you hear me?
Yes, Angelo.
Because my connection is.
I know it's a bit unstable, but yes, we can catch up with you.
Okay, so RACT in obese recipient is another issue. Is let me say a challenge due to the difficult access to the iliac vessels, the increased risk of complication, wound infection, lymphocyte formation, delay graft function. Starting from this evaluation, starting from these difficulties that we also always find when we do a kidney transplant in obese, we analyze in 3 groups in BMI less than 25, BMI between 25 and 30, and BMI more than 30, the complication, intraoperative and post-operative complication, and the functional outcomes. And we can see here that there are no differences between the 3 groups in a series of 169 recipients between obese, overweight, and no overweight recipients. No differences in terms of surgical time. And I would like to underline, to highlight that, yes, the patient with the BMI more than 35 has an increased risk of graft failure, has an increased risk of the graft function, but not the procedure. But because of is rate, the conclusion of our paper, or our study, is that complication rate is not higher when we transplant obese and overweight. And then another study was performed in collaboration with the University of Florence, active guys of our group, with Professor Cerni, Professor Vignolini, Riccardo Campi. And then thanks to this collaboration, we were able to determine the possibility, to emphasize the possibility to do kidney transplant also using a graft from cadaveric donor. This is possible, this is feasible, thanks to a coordination between urologists, nephrologists, the operating staff room. Results in a small series, 19 cases, demonstrate that it is feasible from a technical, logistical point of view without any difficulties, and achieving fantastic post-operative and functional outcomes. The question is, nowadays, the robotic approach can replace the open surgery in kidney transplant. So in order to answer this question, we analyzed, we quantified the systemic response, inflammatory response in open versus robotic kidney transplant using 3 different markers, interleukin-6, angle, and C-reactive protein, by measuring them at baseline, preoperative baseline, and at in the different time post-operative. And we figure out in a series of 24 open versus 25 open robotic kidney transplant, in a series of 49 patients, that there is not differences in terms of inflammatory response in open versus robotic. But yes, there is a trend in favor of a robotic approach in lower inflammatory response. It's difficult to compare inflammatory response. We get, because we are well-selected patients, recipient, and immunosuppressive regimen, immunosuppressive drug that potentially may interfere with the response. however, functional learning curve in RACT, because in the surgeon community, that in some cases the learning curve may potentially affect the result on kidney transplant. And so we analyzed learning curve in 5 centers with more than 5 procedures. And in our analysis, recently published on European Urology Surgery in Motion, we analyzed vascular anastomosis, the rewarming time, the GFR. And we demonstrate that there are no differences in the anastomotic time. So the anastomotic times in different centers are comparable. And the rate of graft thrombosis, at least in our experience, is comparable in open kidney transplant versus robotic transplant. And the learning curve we need to achieve good result includes at least 30 cases in order to decrease the complication rate at the GFR cases to achieve the positive technical result that we want. And we have organized courses in collaboration with the Orsi Academy in Belgium, in collaboration with the Professor Montri, to help the colleagues from around the world want to start with the robotic and transplant program. And it's very important also to consider the proctoring. That's the first procedure in order to avoid any technical mistake, potentially dangerous. So my conclusion are that so far, kidney transplant, at least in Europe, counts more than 290 cases. The last series was published by Dr. Musquera in collaborating with the IRIS group in BJU. And these studies that I showed are the first study and the largest series on RACT. Why we believe the robotic transplant is good, is better in terms of technical result, because you see better, you have a magnification of the vision. So the vascular anastomosis is easier, the ureterial anastomosis is easier. You can take care of the details when you do the procedure. Is a procedure safe, feasible, and particularly is reproducible by the majority of the surgeons that are usually perform kidney transplant, open fashion, and robotic surgery. Low complication rate are recorded while maintaining an excellent gram function. This is very important because the gram function in open surgery are optimal so far. So why not? In obese population, RACT may become a preferred technique when we want to transplant a patient that has a high BMI. And as we analyzed, there is a trend to induce a lower inflammatory response when we do a robotic surgery comparison with open transplant. So in the end, RACT is a less invasive procedure and an emerging attractive procedure for the point of view of a surgeon, and why not also for the patients. Thank you for your attention, and sorry for the problems related to my connection.
Thank you, Dr. Territo, for your presentation. It will be interesting to compare your data later on with Prof. Angelo Modi, and I've got a lot of questions here. So I hope you both can stay with us till the end of this meeting. The next presenter is Dr. Nur Rashid. Now, to most of you, I don't have to introduce Dr. Nur Rashid, but Dr. Nur Rashid is one of the pioneers in kidney transplantation surgery in Indonesia, alongside with Dr. Ari Rojani. He graduated from the Faculty of Medicine, Universitas Indonesia, obtained his doctorate degree, and currently active as a medical staff and lecturer in the Department of Urology Cipto Mangunkusumo National Referral Hospital and the Faculty of Medicine, Universitas Indonesia. He's also the current chairman of the Indonesian Urological Association. So without further ado, I think Dr. Nur Rashid, the time is yours.
Hello.
Yes, Dr.
Can you
Nur.
hear me?
Yes.
Okay.
Please, our time is yours. Dr. Nur.
Hello.
Yeah.
Okay. So after we hear about the talking from two speakers about the robotic kidney transplant, so we back to Indonesian perfection about the kidney transplant, especially when we face with the pandemic era and with the COVID-19. My talk here is about the impact of pandemic COVID to kidney transplant in Indonesia, especially in our center, and then the reason and the benefit behind the kidney transplant restart worldwide and of course in our country. And then the newest protocol to keep our patient safety and the result of kidney transplant in pandemic area in Indonesia. In our country, we start the kidney transplant in 1977, but the numbers still very low until October 2011. We start the laparoscopic living donor nephrectomy. And then 2015, our Ministry of Health asked our center to train another center to create some centers of kidney transplant all over Indonesia. Some of centers is very passionate to do the kidney transplant. But at 2020, especially in March, we found the first confirmed case in Jakarta. And then WHO in the 11th March said that this is a pandemic for the COVID-19. But in our center, we stopped the kidney transplant in 16 months. This is the number, like I said to you, since 1977 until 2011. The good thing of we do laparoscopic donor kidney surgery, the numbers increase until about 160 per year. This is some centers in Indonesia. The color of yellow is our centers. The centers in Java is the orange, and 4 centers in Sumatra, the quite active center in Sumatra, in Padang, West Sumatra. In some centers like in Semarang, Jogja, Malang, is quite active now. But since the pandemic, all centers were stopped. Of course, like in Bali, the red color, there is increased number quite fast. But until now, all of our center is stopped. We know that the kidney transplant is better if comparing with the dialysis, even with the cadaveric donor or the living donor. And also, we know that the living donor will be better with the cadaveric donor. This is not the reason why we did not do cadaveric center, but because until now there is because of social value, and then the what we call it, what they believe about the death, and then we still not doing the cadaveric. Even the system is already can stop. The survival rate for the living donor in Jakarta, especially, we have the same numbers like in several centers in the world. If comparing with the US, New Zealand or Australia, Europe, and also Canada. When we face a COVID-19 pandemic, we can see that even in the Spain, Italy, America, and also in France, but maybe then Prof. Modi can tell us about the what happened in India. We stopped. In April, we decided to stop the kidney transplant. That's make a longer waiting list, higher morbidity and mortality during the procedure for the dialysis, high risk for COVID infection, and no clarity when the COVID-19 will be stopped. And there is no documentation that the transplant can transmit SARS-CoV-2. No intact virus can found outside the respiratory and GI tract. So some country decided to start the kidney transplant. If we see here, the risk of infection comparing the patient dialysis with the kidney transplant, it's about 5 to 16 for the dialysis patient. But in the kidney transplant case, I mean, just about 1.1 until 1.8. And of course, from the mortality rate in outpatient care, inpatient care, and intensive care, it is clearly that the kidney transplant is lower comparing with the dialysis. So we decided, and some country decided to restart the project for the kidney transplant with the reason it has to be COVID-free fast stage for the transplant center, the screening procedure for the donor and recipient for the COVID, and general condition maybe has to be better comparing before the pandemic, and we have to count the post-transplant transmission rates for the patient. We can see here in Italy, they already start at the week 14 of the pandemic, and then here in the Spain, they already start at the end of April. And also, if we see from in the Wuhan, they were doing lockdown in January 23, and they didn't find any new case in March 19, so they decided to reopen the kidney transplant in April, once a week, and then twice a week. After that, they regularly doing every day. What we do in our hospital, we make a special zone for the COVID-19 case. In the rectangular red area on the right down there, we call it Chiara. We specialize area for the COVID case. For the kidney transplant, this is the area with the green color rectangular. So the area was separated from the COVID cases. This is when the patient come, every patient count the temperature on the right top in the consultation. In the room of consultation, and the down of two picture, there is a consultant, a radiologist, nephrologist, urologist, and of course the nurses. We talk about the case for the kidney transplant with the online system, so everybody can get all information before we decided case by case. All country make a screening tool. This is what our hospital doing for the procedure. All the surgeon, also the nurse, will do test for COVID every 2 weeks. And if there is suspected contact with the COVID-19 patient. For the patient, we do test for the COVID 2 times before the surgery, D plus -8 and D -3. And for the donor, after the surgery, we do D plus 2. And for the recipient, we do D plus 4. The operative technique for the we do for the donor in our center, all was doing with the laparoscopic, even for the right side donor, and we put the filter placement to prevent the gas from the intraperitoneally go out to operating theater or the operating room, and we move from the intraperitoneal to retroperitoneal approach, and we're decreasing the pressure of the laparoscopic intra-abdominally. For the surgeon, usually we stay out from the operating theater until anesthesia finish doing their job. This is our shirt when we do kidney transplants. This is a number until the 16th March. For in March, we do still 9 cases. But in April, we stop all the cases. At the middle of March, we start doing the kidney transplant, and you should increase because we found there is no infection of the COVID-19 for the donor and of course for the recipient. So now we do about 9 cases per month. This is the recipient profile. Most of them was male. We have just 1 children in the COVID era. And then from the donor, if we see here, most of them was, this is in the blue color is unrelated. In the green color is related. The unrelated, it's mean emotional related. This is in the green color is biological related. The transplant type, the mostly of them was conventional. I mean, after several months or years of a dialysis, but some of them was preemptive kidney transplant. This is male to female. Most of them was male. From the operative approach of a donor, usually we do transperitoneally, but since the pandemic, the team of donor try to move to retroperitoneally for regular case. For of 37 cases, this is 5 procedure we canceled or postponed for the transplantation. 3 from the donors was tested positive at the D -3. Usually in the D -8, we check the donor and the recipient. If there is negative, so the recipient will go into the hospital, but the donor can still go back home. We have 3 cases after they go back home at the D -3 was positive. So we cancel this procedure. We wait until more than 4 weeks. 1 recipient was tested positive for COVID, and also we postponed more than 4 weeks. But we have 1 cases D -3, the donors was negative. But in this case, the recipient was the second transplant. The donor was his daughter. When we checked 2 days after that, the result was negative because when at the positive one, the CT result was 34. And then we checked twice, and the result was negative. So we just postponed for the kidney transplant just for 7 days. And the good thing, the result, when they go back home, until now was already twice checked for 2 weeks after the surgery, and the result was negative. So the kidney transplant is still preferred for the end-stage renal disease, even in the COVID era. Our hospital, Cipto Mangunkusumo, is already restart kidney transplant program, implementing a new protocol that has been established worldwide with satisfying result. But we still need a further result for the long-term observation for conducted to properly analyze it for the COVID impact in the kidney transplant. Especially for Professor Franzel, thank you. This is our team visiting your center in Ahmedabad, 16 December 2015. I remember at that time, you do about 70 cases per year, and your center doing about, 70 cases per month, if I'm not. For the robotic, and 350 per month for all kidney transplant. Thank you for receiving us there. You make us to make a dream to make a kidney transplant, but we are unlucky because our country didn't buy us the robot till today. And the last year, we tried to buy from the company, the Da Vinci, but they decided not to sell to Indonesia. So we hope in the next future, maybe another company, maybe from South Korea or Iran also can give us the robot so we can reach our dream also. Thank you very much.
It's for an insightful presentation. A dream is still a dream for now, but we'll never know what will happen. It's always gonna get closer. Right. Very
Don't make me cry.
in our questions. Again, I'll start from a technical aspect of the surgery, Prof. Franzel Modi and Dr. Territo, and also Dr. Nur. So since we don't have any robotic transplantation yet, and one of our colleagues from Bali asked whether or not laparoscopy is something that we can sort of start to work with. As I understood from your presentations, people have tried, and only one or two probably picked up the technique quite well. Others will sort of say it's too demanding, but is it worth taking the shot? I think that's the question, and probably Dr. Prof. Franzel Modi can answer this first. Thank you.
Yeah, it depends on your laparoscopic skill, suturing skill, because this is the time-bound procedure. Like we all urologists, we do the laparoscopic pyeloplasty, ureteric reimplantation, etc., and we take care of our own time. Here, however, it is a vascular surgery, and there is a need to understand this procedure very well before plan very well. It is not impossible, and especially in Asia, where most of the kidney transplant are from the living donor, the tolerance to the warm ischemia is very good in living donor kidney transplant. So I think, yes, one can try. Those people, youngsters especially, those who are very skillful surgeon, they can try with the transplant and with the definitive protocol. Laparoscopic kidney transplant is still not a NAT procedure, it is a demanding procedure and difficult to translate to one from another, and that is the reason why. And once the robot is available, we have abandoned. But otherwise, it's a very good procedure. My overall experience is over 177 cases of laparoscopic kidney transplant. So, and we are improving every time when we do it with the enthusiasm team, and you can give the one wall to the resident also, and they can take more time, and then after the rest of the transplant I used to do it. So in that way the teaching was also going on, but by that time we introduced the robot, and so everything is translated into the robotic surgery. But yes, it's worth trying.
After you have the robot, Prof, do you still do laparoscopy?
No, now I don't do the laparoscopic kidney transplant, but I do so many other laparoscopic surgeries also.
Yeah, okay. But laparoscopic kidney transplant. Okay. Dr. Territo, what you say in this? I mean, I guess the big question is whether it's worth taking that risk in the learning curve, though, isn't it? Or what's your take on this, Dr. Territo?
Professor Moody said nothing is impossible. So I agree with this. I mean, laparoscopic kidney transplant is you can do it, but I think that we should think that few surgeons in the world so far, at least according to the literature, are able to do it. One is the Professor Moody, another one is Dr. Antonio Rosales, is a colleague in my hospital. Both are expert laparoscopic surgeon. My point of view is that laparoscopic surgery, generally speaking, is a nice procedure. And the reason why I think that is because also in my hospital, the basic approach for the majority of the oncological procedure or reconstructive procedure like pyeloplasty or radical nephrectomy or partial nephrectomy or radical prostatectomy is laparoscopy. Laparoscopy is still used in my hospital, is still used in many centers in Europe. I don't want to talk about South America, for example, Latin America, for example. In that place, laparoscopic is the main option because there is no robot anywhere. So my conclusion, my point of view is laparoscopic laparoscopic transplant could be an option in expert hands of expert surgeons, but robot is for surgeon that has experience in open kidney transplant and in robotic surgery. So if you have experience in robotic surgery and in a conventional open kidney transplant, you can do a robotic kidney transplantation. It's not the same for laparoscopic surgery. And for example, maybe a provocative discussion could be, is better a partial nephrectomy laparoscopic or robotic? Yes, you can do it laparoscopically, but if you have a robot at your house, in your hospital, it's better to do it robotically. I don't want to talk about robotic laparoscopic versus robotic prostatectomy. That is a procedure still demanding laparoscopic prostatectomy instead of robotic by doing a robotic approach. So everything is possible. You can do it, but so far, literature and daily activity demonstrate that the laparoscopic approach for kidney transplant is too demanding, and just few surgeons in the world can do it. So, in other words, it's not reproducible.
Okay, thanks for the clear message, Dr. Territo. I think, and thanks for bringing in nicely to the next question. I guess people are curious on what actually you need to do before you reach that expertise in robotic kidney transplant. Do you do other robotic kidney, other robotic surgery first? Do you have to start somewhere and finish with kidney transplant? Or you can jump in directly to robotic kidney transplant? And again, I'll go to Prof. Modi first to answer this question.
Yes, I think in my career, I had experience of the laparoscopic kidney transplant, and then when I moved to the robotic kidney transplant, first I did experimental study at Roswell Park Cancer Hospital. We didn't have a robot at our place, so I went there to USA at the 10 days course. It was SIU fellowship, and then I did a vigorous practice, more than 50 hours on the robot. It was an old robot, like S model, and but it gives you the clue about it. And I observed a few robotic surgeons who were there to operate on a human. On the last day of my training, I did a robotic nephrectomy and auto transplantation in a pig. So, and that has given me a lot of confidence. It took a longer time, like 60 minutes plus of anastomotic time. But then at the end, there was a urine output from the kidney, and that has also encouraged us. When I returned to India, we need a collaboration. So without collaboration or without expert directly jumping on a robotic kidney transplant is, we thought that it's difficult. And so my experience was not there with the robotic surgery at all before the, and we brought the robot in January 2013. So before that, there was nothing. And so that's why we have a collaboration with Rajesh Alawat's team at Medicity Medanta and Dr. Mani Menon from Detroit. And together we did first 6 robotic kidney transplant at my center. And I started, my first robotic surgery was kidney transplant. I never had any other experience of other robotic operation. However, just the previous experience of laparoscopic kidney transplant, then the in presence of mentor who were expert in robotic surgery itself, and together we could achieve it. And once we sat the procedure on, then after we never looked back, and then we proceeded to the transplant. So I think the principle is first do no harm, and at the same time teamwork is the most important thing in presence of mentor.
Thank you, Prof. Dr. Territo?
Yeah, I think that the best option, the best training, and the best route to start a kidney transplant program in a safe way is, first of all, is an experience in robotic surgery, including radical cystectomy, possibly with the intracorporeal ileal conduit or urinary diversion, doing radical prostatectomy, doing partial nephrectomy. In other words, as to be confident with the suture. Therefore, I think that you need experience in open kidney transplant, because if you have no experience, if you have no idea what is a kidney transplant, including open surgery, I think could be almost impossible or too difficult to start with a kidney transplant, because I think it's a nice, at least in my opinion, I figure it a procedure, a nice procedure that I love it, but it requires many technical details, requires a lot of tips and tricks in order to achieve good functional result and to minimize the complication in terms of vascular complication, in terms of ureterial stenosis, and so on. So that experience in robotic surgery, experiences open kidney transplant, and since there is possibility nowadays to train on porcine model, I suggest all the guys who want to start with the program in robotic kidney transplant to do the course. This training at Orsi is 3 days course is on porcine model, where you can try directly the vascular anastomosis on the porcine model. And I told you, and I would like to emphasize that the porcine model is the best model to try anastomosis, to understand the details of the vascular anastomosis, because the anatomy is the same. The anatomy of the vessels in the porcine model are absolutely identical in comparison to a human. So if you are able, let me say, to perform anastomosis, vascular anastomosis during the 3 days course at Orsi in Belgium, you will be able to perform a vascular anastomosis in your hospital. After that, we want to highlight the importance of the proctor during the first cases. It is because first cases are the more challenging because they are stressful, particularly if you start your program with living donation, with the graft from living donation. So proctoring the first cases is fundamental, possibly, potentially mandatory in order to avoid any technical mistake that can compromise the results. And when it's possible, start with the graft from cadaveric disease, cadaveric donor. The problem is that the cadaveric donor are not scheduled. So in the first cases, maybe since you need proctor and you need a guy that is proctoring your procedure, you will include cases from living donation. But anyhow, also from living donation, you can start using the graft from living donation. You can do the procedure safety for the patients and without no tumor coronary.
Okay, thank you, Dr. Territo.
This is my idea.
Okay, thank you. So again, I would like to remind all the audience, if you've got any questions, please feel free to write them down in the question and answer chat box, and we'll be happy to look at them. We're going to shift a bit our focus to the pandemic and how it affects kidney transplantation globally. And Dr. Noor has certainly highlighted that we've only restarted our transplant program in around May. There's one question Dr. Rinaldi asked, is there any special treatment to both donor and recipient who is infected with COVID? What should you monitor to keep the transplantation eligible? I would like to clarify to Dr. Rinaldi Zainuddin first that we don't have any cases where our recipients had COVID after transplantation. So all the cases that we say positive were detected before transplantation, and that shows how stringent or how effective is our screening system. But I'll let Dr. Noor answer that, and perhaps to answer Dr. Pandey's question from Bali again. As far as you know, are there any changes regarding immunosuppression regimen given to recipients in your center during this pandemic? And I'll leave that probably to Dr. Territo and Prof. Modi. Dr. Noor.
Yes, like my presentation before, we make a straight test for the COVID, D-8 and D-3. If there is positive between there, we cancel. Even the recipients are already received the immunosuppressant. So we postpone usually more than 4 weeks, except one case, because the recipient is already started with the immunosuppressants, and also we do wash out for the antibody, because this is for the second transplant for 3 times. And then so the donor was his daughter, and then we check for 3 and 5 days after the positive, and the second twice check was negative. So we make a decision. Of course, we talk with the pulmonologist and infection disease. They agree to do the kidney transplant 1 week after the patient was negative. So we do. This is the first donor were already negative for 1 week, and the result, even for the donors and the recipients, still negative until 2 weeks after the surgery. But all the case, we postpone if we found the positive COVID. And of course, for the treatment, like our team doing, there is no different if the patient not positive COVID. The procedure was still same like before the pandemic. Thank you, Dr. Adi.
Thank you, Dr. Noor. And how has it affected you, Prof. Modi? Any modifications?
Yeah, a lot of modifications. We had a pandemic, epidemic of COVID, and in India, 24th March onward, everything was locked down. So we completely stopped our program, no traveling, nothing was possible also. So patient used to come from different part of the state and the country, and the traveling was stopped. Till June, we didn't do much transplant except that 3 deceased donor transplant which we carried out, where the organs were procured from the special permission from the government, and the medical team could travel to the donor hospital. Out of that, one was a pediatric donor, and 2 other were the adult donors. Pediatric deceased donor, 1-year-old child, and so the problem was transplant itself and how to carry out in a. So what we did is that the donor hospital did not have a great facility to carry out the transplant itself. So we transferred all the equipments and gadgets and the recipient also to the donor hospital, and then temporarily we create a system and we did transplant. That was area which was not coming under the micro-containment zone, and we could carry out successfully transplant, keeping the recipient there only, following the transplant, and then he was moved back to his place where. And 2 other cases, we carry out transplant by bringing the organs to our hospital by the time the prohibitions were not there. The protocol was in a deceased donor transplant is there should not be a prior history suggestive of COVID-19 symptoms, maybe cough, fever, or anosmia or something like that. And the CT thorax of all the donor was mandatory. We made it mandatory despite the fact that the RT-PCR assay for the COVID-19 is negative. Still the CT thorax was made mandatory, and any patch is present, like 2 donors additionally. Recently we had 2 donors, deceased donor, and they had a patch in the lung, highly suggestive of COVID lesion. The scoring was 4/25, and that was discarded at this point of time because of, even though we know that there is a very minimal transmission through the blood, but I think the Indian Society of Organ Transplantation guidelines suggest that you have to discard those organs. Recently, in a living donor transplant, we have started from the mid part of the June, and slowly, steadily, we are doing 2 to 3 transplant a week only. We used to do about 10 transplant a week, and now we are doing about 2 to 3 transplant, because our concern is donor and recipient. All the donor and recipient have a 48 hours prior to the transplant having COVID negative test, as well as they have to undergo the CT thorax at this point of time. Once the CT thorax and both the tests are negative, we proceed and we take a special consent and making them understand that post-transplant donor itself, himself or herself, may have an infection. Then it is very important to, because recipient is immunosuppressed and chances of immediate perioperative infection could be there, but then these are not very symptomatic. The IL-6 related storm is not there, and hence these are protected patient. But donor, if they get it, maybe do not know what kind of immunology they have and reaction to the COVID-19. And fortunately, we didn't have any donor who had infection afterward. But our worry and concern is that, and we strictly monitor them at this point of time, and that's why number of transplant are less. As far as protocol of immunosuppression is concerned, it has not been altered, and we do not do the transplant of a very, old patients, diabetes, hypertensive, too much hypertensive, and comorbidity like IHD, which is present. Most of the transplanted patients are relatively young, and at this, once we learn our lessons from the young recipient and donor pair, then after we will slowly shift to the high-risk patient transplant also, because the world literature suggests that the risk factors for COVID-19 infections are old age, especially 60 years of age, and IHD, diabetes, etc. Also, the literature survey says that recently operated patients are not developing the mortality related to the COVID. But those who have 5 years or more than 5 years of transplant, then they are more likely to die because of the COVID disease. So the extraordinary precautions, we are doing follow-up for those patients who had been transplanted 5 or 10 years before from now. And I think a rigorous instruction to them and maintenance immunosuppression protocol is same, but the extra precaution are to be taken to them, especially not to go out and keeping the social distance, keeping mask, etc. are repeatedly taught to them, so that we can because it is a prevention only is helpful. There is no cure as such in this disease. So this is what our protocol is right now.
Thank you, Prof. Modi. We have about 10 to 15 minutes, one question. Dr. Territo, what's your say on this? Especially, I think, on the use of, those sort of bomb immunosuppressive, anti-IL-2, anti-metabolites, ATG, things like that. Do you still use that regularly in the pandemic era or not? Or?
Well, good question. Honestly speaking, we stopped our program between March and the end of June. So no kidney transplant were performed during this 3 months. Now that from the beginning of, from the first days of July, we'll restart with our program. And as far as the immunosuppressive regimen, there was no differences, and there are no differences in during this month in doing that, in administering that to the patients. Of course, we do a COVID test and chest X-ray the 24 hours before a kidney transplant, and we are limiting the family contact, the family visiting, and no other differences in comparison to the pre-pandemic area we are using. Again, we stopped all kind of kidney transplant, both from cadaveric donor and from living donor during the pandemic, in order to minimize, to abolish any risk of infection in our institution. So honestly, what we changed was just the test, COVID test, 24 hours or few hours before, when we have a kidney transplant from cadaveric donor. We try to do it in the 6-10 hours before the transplant, and in order to reduce the cold ischemia time of the graft, and nothing more. The regimen, the immunosuppressive regimen, is the same. No differences.
Okay, thank you, Dr. Territo. While I'm on Dr. Territo, there's one question from our colleague in Bali again, Dr. Pandey. Surgery. Did you look at IL-2 as well? Is there any particular reason why you only examine IL-6 and not IL-2? I think that was the question. And when do you actually measure the IL-6 after the transplant? Because that will determine the level also, though, isn't it?
I did not hear the first part of the question.
I'll repeat that, Dr. Territo. So in your paper, examining inflammatory response after robotic kidney transplantation, when do you test for IL-6? Because the timing will determine the level of IL-6 after transplantation. That was the question number one. And number two, why did you only look at IL-6? Did you look at also IL-2 or other inflammatory markers?
Yes, good question. So in our study that is in publication in the World Journal of Urology in the next month, we measured the interleukin-6 and all the inflammatory markers, including ENGOL, this a marker on the neurotrophic wall and CRP, C-reactive protein, in the baseline, so in T0, that it is pre-operative, and then at T1, it is immediately post-operative, T2, this is 6 hours before, later, 24 hours, 36, for 2 days, and 5 days before the surgery. This is the way, this is the timeline that we used in our study. And which was the other question?
IL-2. I think that's quickly on IL-2. Interleukin-2, so you check them.
No, interleukin-2, just interleukin-6.
Just interleukin-6, okay.
Interleukin-6, C-reactive protein, and NGOL, not interleukin-6. Yeah. Not interleukin-2, not interleukin-6.
Yeah, okay. We're going to return to the sort of technical aspect of the surgery. A question from, I lost the question here. Hold on. A question from Malaysia again to Prof. Modi. What pressures do you use for the pneumoperitoneum, Prof? Does too high a pressure risk reduced blood flow to the transplanted kidney? So that was the question.
Yes, typically when we prepare the bed, initial port placement is around 15 millimeter of mercury, which as soon as the incision of the peritoneum start, it reduces to 12 millimeter of mercury pressure. And when the graft is reperfused at that time, we further reduce to 8 millimeter of mercury pressure. We wait for some time for the graft to start functioning. Once the urine output establish, everything occurs, then after we restore the pneumo to 12, we flip the kidney on the opposite side, we watch that the urine output comes. The important aspect is anesthesia and how much fluid is to be given, because typically when patient is in a head down position and all the diaphragm is pushed up, the cardiac output also would reduce and the lung compliance also reduce. So the anesthetists don't give a lot of fluid to start with, but once the graft starts functioning, they slowly start giving more and more fluid at this point of time. But the pressure remains the same, 12 millimeter of mercury throughout the procedure. Then after, once the graft is perfused, and it is having no negative impact which we found.
Any difference with your practice, Dr. Territo?
No, well, small differences because we try to use 12 millimeters during the vessel dissection, and thereafter, when the graft is inside, we try to maintain keep the pressure around 10 millimeters of mercury. So no differences. Problem is that we demonstrate that the pneumoperitoneum potentially doesn't affect the graft function. However, you should consider that there is the pneumoperitoneum of the living donation. I mean, if you do laparoscopic living donation, the graft is already potentially impaired by a pneumoperitoneum for 1 hour and a half during the living donation. Laparoscopic is performed in our center, and thereafter the time of robotic surgery. So I think that in our study and in the majority of the study, in the daily activity, pneumoperitoneum doesn't affect the graft function, but we have to consider it. We cannot make larger the time of the kidney extraction and the kidney transplant when we use a minimally invasive approach like robotic surgery for transplant and laparoscopy or robotic surgery also for the nephrectomy.
Okay, thank you, Dr. Territo. I think we will have about 5 to 7 minutes left, and there's an interesting case shared here by one of our audience. It's a difficult pediatric kidney transplant surgery case, and it's always nice to close this insightful meeting with a challenge to our panelists. A pediatric kidney transplant case, 12 years old boy, had multiple surgeries, sacral agenesis, vesico-urethral reflux, multiple surgeries to do bladder augmentation, but then it failed. You know, multiple scars on the abdomen. Obviously, we only do open surgery, and possibly, you know, the peritoneum is non-existent. What do you do in this case? And I'll probably, you know, ask all of you, our experts, starting with Prof. Modi, maybe.
Yes, it's a challenging case, and this is typical urological indication for the kidney transplantation, where multiple surgeries done. We first and foremost would like to assess the voiding pattern of this patient, the infection-free urine, the correction of reflux is there or not, and whether the child requires clean intermittent catheterization by himself or by the attendants or not. So maybe urodynamic study may be helpful in this case. Since he's already been augmentation cystoplasty done, the mucus is going to come and there is never going to be bacteria free. But at the same time, the mere presence of bacteria doesn't preclude the kidney transplant in this group of patients. The second is persistent reflux is there and urinary tract infection is there or not. I would like to ask if it is there, the child may deserve the nephrouretrectomy because high-grade reflux sometimes, and especially in presence of infected urine, it gives a lot of problem post-transplant period also, and the child becomes febrile, and then multiple hospital admissions do required. So our protocol is to knock down those kidneys and ureter prior to transplant. Once the child is prepared for transplant, like a psychological preparation of the parents, the child itself, and the understanding the dynamics of the bladder, right? We can go with the transperitoneal transplant, straightforward midline incision, and mobilizing the bowel up, and like a cattle maneuver, you can mobilize the colon, mobilize everything upward towards the, like what you do in a deceased donor transplant, the retrieval is carried out in the same way. You can do the mobilization of the entire colon and moving the colon up, small bowel up, exposing the vena cava and the aorta, and transplant with the cava and aorta directly in case if the other vessels are not available. However, if the common iliac vessels are available, you remain lower down and do the transplant with the common iliac vessels also. And the graft may remain transperitoneally in that case, but it is behind the bowel, so behind the cecum. So if it is behind the cecum, there is no need to fix the graft most of the time. The case the bladder is not available, and we need to understand whether pre-operatively we need to do the continent urinary diversion or not. So using the Mitrofenov procedure, if appendix is available or so, we have to do a major reconstruction while child is on dialysis and understanding the risk of it. Once we carry out that, 3 months later, we do the transplant and implanting the ureter into the continent pouch. That is what my strategy would be.
Thank you, Prof. Modi. And I'll move to Dr. Territo. I'll just like to add more information. These kids already and bilateral nephrectomies due to the persistent hypertension and hyperkalemia. So the native kidney is no longer the problem. But I agree with Prof. Modi. The problem is of course the bladder and where to position the graft. Dr. Territo.
Yes, honestly speaking, in our hospital, pediatric kidney transplant are not performed. But in a catastrophic abdomen, I mean, in case of multiple surgery in the abdomen, and considering that many times you need to do a nephrectomy, radical nephrectomy in this recipient, an option that could be considered is the orthotopic kidney transplant, using the renal vein and the splenic artery. I mean, it could be an option. Is more difficult technically from a technical point of view, but could be an option, particularly if you have a pelvis that is was already that already got multiple surgeries. so you can do at the same time a radical nephrectomy and a orthotopic in a transplant. But again, honestly, in our hospital, we don't have experience in transplant in children.
So, Dr. Nur, do you have anything to add to this?
Of course, this is stressful for us, for all, of course, our team, because the catastrophic area of the peritoneum, there is no more kidney area because they're already doing nephrectomy on the right side. And then in the pelvic area is already done for several surgery. So I think we have to doing the recipient first. We preparing the space area if we can prepare it that, and then we do for the donors. So don't hurry up with the donor first because we don't know exactly what we face south, and of course we will make angiography for the artery, and then of course for the vein also. But we have to know, like Prof. Franzel say, maybe we have to put in the aorta or the iliac, common iliac. We don't know exactly. So we have to check first after we exactly know where is the place to put there, and then we take the kidney for the donor. That is what I think. How about
thank you,
opinion, Prof. Franzel?
So thank you. I think to add to that, Prof. Franzel or Dr. Territo, if we plan to reimplant the graft on the iliac vessels, rather than placing it behind the bowel, do you have any experience of actually covering the graft with, say, mesh or something like that, and then attach it to the abdomen? Will that work?
That question comes especially when we do extraperitoneal transplant, and when the child is very small, like and growth retardation is there, and very small child, small iliac fossa is very small, and donor kidney is very large. In that case, when you try to put it and close the abdomen, then there is a chance of compartment syndrome also. And that can lead to as soon as you close the abdomen, there is an urea or a reduction in output, urine output do occur. So yes, we have experience in about 3 to 4 cases to put a absorbable mesh, not a the standard mesh which is available. Proline mesh, no, we don't use that, but we use the absorbable mesh. And then over a period of, I think none of the case had an infection also. But the graft because post-transplant graft is going to swell further because of the edema and the size increases, and that can produce more problem with the compartment syndrome. So to avoid that, the vicryl mesh is very useful, and then just the skin is to be closed over the vicryl mesh, subcutaneous tissue and skin. No muscle closure is allowed, and then we didn't find any problem subsequently in all these cases.
Okay, before the final question, Dr. Territo, do you have anything to add to this? If no, I'll just move on to the next question.
Well, just one case I remember using a mesh. It was performed not by myself, honestly, and but yes, one absorbable mesh. I agree with Professor Moody. In this case, the choose is with the absorbable mesh. But honestly, I remember in my experience, one case not performed by myself, performed by my boss. So honestly speaking, I have no experience with this kind of case so far.
Okay, thank you. So one final question, Dr. Irfan Wahyudi from Jakarta asks, we've discussed about robotic aided transplantation potentially replacing open conventional surgery, but are there any limitations on this? Are there any contraindication where you shall say, probably you should just go back to the old surgery? And I'll give an opportunity to Dr. Territo first, probably, and Dr. Franzel to close it before I finish the whole session. Dr. Territo, please.
Yeah, there are limitations of the technique, of course. As all the time when we start with a new procedure, new technique, a pioneer technique, we have limits. One of the limits that we think is related with the open approach is the presence of plaque, arteriosclerotic plaque in the artery. So this could be a problem because in robotic surgery, you don't have any tactile. feedback. So if you have a plaque and you clamp in the through this plaque, you can potentially provoke a massive embolism to distal arteries. So this is one of the limitations. You cannot include so far patients with arterial plaque. So in this case, you can include when you want to do a robotic approach, the best option is patients in preemptive patients, so without any plaque, with no problems in terms of risk of embolism related to the absence of tactile feedback when you do the clamp before starting the arterial anastomosis. So you should select very well the cases for robotic kidney surgery from a technical point of view. Another problem, another limits at least, is the logistic point of view. I told you that the best option to reduce the stressful is to start with cadaveric graft, graft from a cadaveric donor. But if you are starting with a new procedure, you need or you would like to have the same scrub nurse, the same assistant, and possibly not in the during the night, not during the weekend. So you would like to perform the procedure in the best condition. And this is a limit. If you want to transplant, if you want to include in your series, in your program, graft from a cadaveric donor. And thereafter, the other limitation that we would like to emphasize is related to the rewarming time. I mean, we demonstrate that there is any potential impairment on the graft due to the pneumoperitoneum, due to the high temperature inside the abdominal cavity. But yes, you have to consider that you have a graft inside the abdominal cavity with exposure and temperature to 38 degrees. Despite you are continuously adding ice lash around the kidney, you are not sure that all the kidney surface are properly maintaining in a low temperature between 15 and 20 degrees, as described by Rajesh Alawat and Professor Menon in the ideal phase 2. So you have potentially a damage related to the ischemia, potential damage related to the not properly, not adequate maintaining the low temperature of the graft. And this is the reason why we are in progress with the development of a sort of machine able to maintaining a constant low temperature of the graft.
Okay, thank you, Dr. Territo. I'm really sorry I have to stop you there, and I'll move on to Prof. Modi. Really sorry. Due to time.
There are contraindications for the robotic kidney transplantation, which was defined well before we started the transplant program. And there are absolute contraindication is a multiple surgeries done in the abdomen, like you mentioned about the child. You can't go with the robotic transplant when the resection, and say for example, bowel resection and anastomosis is done, the likelihood of a lot of adhesions. The lower segment cesarean section in a female is not a contraindication, and so the abdominal hysterectomy in most of the cases, because we can dot down those adhesions very easily if it is uncomplicated. If it is complicated, then certainly we would not like to do the transplant like this female recipient with a large multiple fibroid and the bulky uterus or so, and then it occupies almost whole the pelvic cavity or so, would not like to do the transplant in that group of patients. Also, we put a patient in a stiff head down position, and the patient having history of glaucoma or the raised intraophthalmic pressure or a benign raised intracranial hypertension, we are not taking those patients also. Further, like uremic cardiomyopathy, we present ejection fraction less than 30% in a 2D echocardiography, or patient is a heavy smoker having a compromised lung value where the lower down position, head down position could be a problem and anesthetic challenges are there. We would not like to do the transplant of this patient. Last but not the least is large space occupying lesion like a autosomal dominant polycystic kidney, which doesn't allow the pot placement safely, as well as the chances that your instrument would clash, especially if it is going down right up to the pelvis. We would not like to do the robotic kidney transplant in this group of patients. However, that is a relative contraindication. We can have a selection of the case. If you're expert, you can later on include few of them as an indication for transplant. But especially in early part of your training, we should avoid all these patients for the transplant. That's what, as far as atherosclerosis is concerned, yes, we do accept the atherosclerotic arteries because if patient is a candidate for open transplant, then there is no difference of a handling of the artery for the open versus robotic kidney transplant. In fact, it is very gentle, and what is the important thing is we put a double bulldog on a proximal part of the artery, so that sometimes what happens if you put a single bulldog and it is a rigid atherosclerotic artery. So after making arteriotomy, the bloods keep on coming out, so it's better to put a more extensive dissection of the artery is required in that case, and you flush it out that, and the chances. In case the plaque gets detached, you fix it the way you do it in open transplant. Fix it with taking the double arm needle and passing both the needle inside out and just put a note on the outer wall, and then the plaque can be fixed. That also can be done robotically. We have done only in one case, but it is safe to do it, and it's not, again, a relative contraindication. I fully agree with Territo, Dr. Territo, that in early part of the surgery or robotic training, or you should not take these cases, but later on, once you're experienced, you can take those challenges. Yeah.
Last say I'm going to give to Dr. Noor. Is there any message for our friends who's going to restart or thinking of restarting a living donation program before I close the session, Doc? A quick message, maybe 20, 30 seconds, please.
Okay. In our country, we already have a National Kidney Transplant Center. So I hope our Ministry of Health help our National Kidney Transplant, KTN, National Kidney Transplant Committee to start registry for the donors and also for the recipient. Because without registry, we cannot increase our number for 270 million people. We just as doing about 200 per year. It's so small. So we need our Ministry of Health to help us to increase the number of kidney transplant also, with the registry system in our country. So for our colleague in some centers in Indonesia, just keep take your support for the kidney transplant to make kidney transplant increase the number and the quality in Indonesia. Thank you. So
thank you, Dr. Noor.
Prof. Modi, for stay with us until finish today. Thank you very much.
Thank you. Thank you very much.
I'd like to thank all speakers.
Thank you very much.
Dr. Rashid, especially taking this time of rest and being able to share your expertise and knowledge with us. Again, thank you very much. I will not conclude this session because I think the evidence and discussion will be more to come. And I'll give it back to the Master of Ceremony to close the event. Thank you.
Thank you, Professor Modi, Dr. Noor, and Dr. Territo for all the very comprehensive and insightful topics. And also Dr. Aldi for moderating the very active discussion session. Now we are coming to the end of tonight's event. On behalf of the committee, I would like to thank PT Astellas as the sponsor for today's event. Prof. Franzel Modi, Dr. Nur Rashid, Dr. Angelo Territo, and Dr. Aldi as our esteemed speakers and moderator. And also, of course, to all the participants and everybody who's involved in this event. Again, I'm happy to let you all know that all of the recordings of this event will be uploaded on our YouTube channel. And don't forget to fill the feedback form at the end of this session. We also like to inform you about our next big event. There is annual scientific meeting of Indonesian Urological Association or ASMI-UA in December 2020. We are looking forward to see you all there. Lastly, don't forget to stay safe and hopefully we can overcome this pandemic season together. I'm Utari. Thank you and wassalamualaikum warahmatullahi wabarakatuh.
Program PSL memberikan kesadaran melalui pemberian sekali sehari, mengurangi intrapassien variability untuk memberikan kadar tacrolimus yang konsisten dan dapat memperbaiki tingkat kepatuhan pasien, di mana keduanya dapat meningkatkan outcome jangka panjang. Program XL. you.